Hello, and thank you for joining us. My name is Brian Zimmerman, and I'll be your moderator for this session. Before we get to some introductions, I'd like to start with some tips to help you participate in the session. Please use the Q&A box to enter your questions for the speakers. We will address them as they come in, and at the conclusion of the presentation, we will discuss some of your questions with the speakers. To engage with your fellow attendees, please use the group chat feature. If you experience any technical issues, please email support@mig.cc for assistance. And so we're going to begin with a little intro here. The quadruple aim has become increasingly important in the current value-based healthcare environment. Because of this shift, hospitals today are prioritizing the four goals of the quadruple aim: lower costs, improved outcomes, a better patient experience, and improved provider satisfaction. Today, the panel will discuss how their programs within their hospitals and health systems are aligning with these four buckets, their perspectives on how robotics aligns to these goals, and how the evolution of value-based care has impacted their hospital initiatives. So to begin, I'm going to have each of our panelists here introduce themselves and maybe in about 30 seconds or so discuss their own alignment with the quadruple aim. Brian, why don't you kick us off?
Hi, my name is Brian Dawson. I'm the System Vice President for Perioperative Services for CommonSpirit Health. The quadruple aim is extremely important to us as we are very patient-centered. We want to make sure that our patients and providers have access to the robot when they need it. Therefore, we have several initiatives to make those tools available to them. We're also looking at consolidating our equipment around centers of excellence, bright spots, if you would. We're looking at working with providers in the community to make sure that each of them not only has what they need, but we can streamline the necessities of different pieces of equipment around practice groups. Again, we want to make sure that our clinical outcomes are the best and that our patients have the best experience when they come to one of our 120 facilities. So thanks, Brian.
Excellent. Thank you, Brian. Good to have you here. Dr. Talamonti, let's start to you next.
Hello, everyone. My name is Mark Talamonti. I'm the chairman of surgery at NorthShore Health System, a 9-hospital regional healthcare system on the north side of Chicago and now dispersed throughout the western suburbs. So we're a growing healthcare system. And as the chairman of the Department of Surgery, the fundamental essence of my job are the quadruple aims. And what I mean by that is it's imperative. My main responsibility is to make sure that we are always providing great outcomes and the standard of care for our patients. Part of that means incorporating innovative strategies, of which one of the most prominent is robotic surgery, and making sure that that technology is brought on in a very cost-efficient fashion, one that focuses on good outcomes, safe outcomes for the patient. And obviously that's predicated upon the training of the surgeons, the nursing team, the satisfaction of the team delivering the care. So really the fundamental essence of what I do as a surgical chair is to meet the goals of the quadruple aims.
Thank you, Dr. Talamonti. We truly appreciate you being here and being a part of this discussion. Rick, why don't you round off our introductions here?
Rick Harrell. I am the Assistant Administrator for Surgery and Cardiac Services at Sutter Medical Center in Sacramento. Sutter Medical Center in Sacramento is one of the Sutter Health hospitals, of which there are 24. The quadruple aim, we would summarize as saying kind of the ultimate experience and satisfaction, whether you're a provider as well as an employee or a patient or a third-party provider. And so as a result, that has really been kind of the fulcrum of how we've approached our care over the last number of years. And our partnership with Intuitive and our robotic assisted program has really been the impetus that has helped drive all of our procedural services toward that very high satisfaction perspective.
Thank you, Rick. And I think that brings us to the sort of first bucket of the quadruple aim that I'd like to focus on with the first couple of questions here, which is patient satisfaction. I think it's important to begin with this one because it's at the core of what each of you are trying to do every day. So the question that I'd like each of you to answer is, how do your robotic surgery strategies support your overall community needs? I can address it to somebody, but I'd love it if someone just was eager and jumped at that question.
Well, Brian, at CommonSpirit, the most important thing is that our patients have access to care. And so we've strategically adapted programs to make sure when a surgeon needs a robot to provide that care to a patient, they have access. So we've made sure that through our physician portals, that the physicians can choose from several hospitals in their geographic area, because we want them to be able to book that case, whether it's in their block or outside of their block, at that patient's needs. We also want to make sure that their experience at our facilities is among the best, that the team is prepared and the patient receives the quality of care that they're looking for. And that we get them out of the hospital as soon as possible. That's the best part about robotics. Their hospital stay is diminished. And so we can get them back home, back on their feet, and back into, you know, the daily living habits that they have.
Thank you, Brian. Rick, curious to say what you would have to hook on here to Brian's comments.
Yes, I believe that robotic-assisted surgery and our patient experience, we had to basically redesign how we delivered care for us to optimally use minimally invasive surgery. And so our pain management process has changed. Our preparation of patients has changed, what our outcomes and evaluations are afterward, the team concept, how do we achieve having 24-hour access to the robots? And we are a regional hospital within our health system. So we have a number of hospitals that are seating us patients within our own health system. And so we have patients that we may not have met before having robotic surgery here. So we've just redesigned how we deliver care globally as a result of this, the motivation that robotic-assisted surgery actually provided for us. And it really gave a level of engagement from our physicians in particular that could really represent their patient population and say, this is what our patients really want. And so when we were able to partner together to do that, we have significantly optimized our entire process. Patients are pain-free, and as a result of that, most of them have an extremely short length of stay and recover very fast. And those are the measures that we know as a measure of success for our overall program.
Thank you, Rick. Fascinating to hear about robotics as this driver for broader change at your organization as well. Excellent. Dr. Talamonti, why don't you answer this question as well? How do your robotic surgery strategies support community needs?
I think the patients in any community, but especially nowadays, when they have so much access to information on the internet, they basically want you to take great care of them. And that's not unexpected. That's what every patient and every family wants. They want you to take great care of sick people. And that's what the patients in any community would expect. And accordingly, that has changed over the last several decades. They expect superior outcomes with minimally invasive approaches. And we see that throughout surgical subspecialization. We fix aortic valves now percutaneously. We fix aortic aneurysms with stents instead of laparotomies. They see a much less invasive and debilitating approach to various cancers like head and neck cancers and breast cancers. And for much of what we do at NorthShore, including thoracic surgery, colorectal surgery, complex general surgery, complex hernias, foregut surgery, and then even hepatobiliary and pancreatic surgery. Much of those goals can now be accomplished with a minimally invasive approach. And quite simply, using robotic technology gets us to that minimally invasive pinnacle faster and safer.
Thank you, Dr. Talamonti. I got a follow-up question for you as well. Culture from within a hospital can certainly play a very significant role in patient satisfaction. So can you tell us how you've built a patient-centered culture within your hospitals?
Yeah, it's a good question. If you look at reported outcomes when patient-centered programs have been into place and put into place in healthcare systems, without a doubt and unequivocally, one of the most important metrics is, do the patients perceive that what they are about to encounter was communicated to them well. So in any patient-reported outcome metric, it's about communication. It starts with communication. So in terms of a robotic program, we go to great pains in the preoperative preparation of a patient about to undergo a complex robotic procedure and explaining what the advantages are of the robotic approach, what the options are versus laparoscopic versus open, and really engage in a and an educational process to bring those patients to a comfort level where they truly understand what they're about to embark upon. And then on the morning of surgery, again, a time when you can imagine there's a great deal of stress and apprehension for patients. We have the OR team, the robotic nurses that are the nurses that are going to work on the robotic program that day or in the robotic case. They come and meet the patient and introduce themselves to them and tell them how they're going to be positioned in the operating room, what to expect. Many times they're sedated before the case starts, but they give them a sense of calmness that these are experienced nurses using, extraordinary technology to perform these complex operations. Again, a sense of communication that we've got control of this, not to worry, you're in good hands. And then post-operatively, we make a lot of effort to explain to the patients what was done during the surgery, what did we find, were there unexpected findings, and nothing. Patients I've seen never appreciate more than you say, we were able to do the entire case robotically. We accomplished our goals, whether it's an oncologic operation or an abdominal wall reconstruction, and then spend a lot of time explaining that to them and what they expect on the recovery. So I think the robotic program is an opportunity to enhance patient communication, which will invariably result in better patient-reported outcomes.
And speaking about outcomes then as well, just going a little bit further on that bucket, with the rapid growth in various specialties, general surgery, colorectal, thoracic, how have you built a commitment to these newer specialties? And also another piece of that too, sort of there's some financial misconceptions there. Have you proved those to be inaccurate through building up your robotic service line?
Yeah, I'll take that question on it since it seems to flow so smoothly from the first question you asked me. I think it starts with leadership, right? If you've ever seen a program start in robotics that fails, it's because there's not support at the department chair level or the division chief level. Too many times I've seen recruits say, or programs say, well, we're going to start a robotic program in liver surgery or in complex GI surgery. And so they recruit somebody right out of training to bring in and say, well, that's our robot expert. Well, that's not going to work. You can't give somebody with that much inexperience that much responsibility. So it really starts with leadership. And whether it's the department chair doing a robotic Whipple or a division chief using robotic technology for colorectal surgery, it starts there. And then that follows with strategic recruitments. We just have made an absolute commitment that we're going to recruit specialty trained surgeons. So we're not recruiting a general surgeon who's going to dabble with some hernia repairs and a little bit of HPB and an occasional colorectal case. We recruit fellowship trained surgeons under the guidance of a committed division chief or department chair, and then bring them in to a culture where robotic surgery is encouraged. And a minimally invasive surgery approach is preferred over open surgery when possible. And then we standardize their approach to the patient so that they don't have to try to figure out how to do the operations. It's already a part and parcel to the way we approach patients. And thoracic surgery is a great example. We recruited a young surgeon. He's about 5 years out of his training. He's adopted robotic technology and robotic surgery for thoracic oncology unequivocally and unabashedly. And then we just recruited a young surgical thoracic surgeon from the University of Pittsburgh, who she is similarly trained and similarly enthusiastic and committed to developing that robotic program. I think that's the best recipe for success. You have to have it at the leadership level, you have to have strategic recruitments, and then you have to have everybody on the same page with standardized approaches and reproducible outcomes.
Brian, I love the answer that he provided, and we're doing the same thing. The only couple of things that I would add to it, as he so expertly said, leadership is key. So that head of a robotics committee is extremely important so that all of the different specialties that are using that tool feel that they have equal access. We've also added to that nursing leadership so that the team that supports these surgeons is well trained, the surgeons know them, and so that everything is well oiled. The last piece that we've added is business. We've added business managers to the program to provide data that we work hand in hand with Intuitive to provide so that we could look at data, at outcomes, at cost. If two surgeons are providing the same procedure, but one has a cost that's a little bit higher than the other, can we pinpoint what that is? It's usually a piece of equipment. It's usually an arm or an instrument. And so we bring those two providers to work together so that one understands that even though their costs are less, their outcomes are still the same. So, I love the answer that you heard, and I would just add those couple of things to it.
Some great points, Brian. I want to build on your comment around access. I think that's an important component of all of this. 24/7 or expanded access seems to be a real critical focus for a lot of folks. I guess, Rick, then turning to you, how are you working towards making 24/7 access a reality? Do your surgeons have unrestricted access to the technology?
Yes, it was a concentrated effort that we embarked upon a number of years ago, maybe 3+ years ago. Our acute surgery program, which are the patients who come through our emergency room, we have a dedicated hospitalist or surgical team that cares for those individuals. And they wanted, of course, to be able to use the robot for their procedures, regardless to what time of the day it was. So we made a concentrated effort. It is a very multidisciplinary team of individuals, of scrub techs, nurses, as well as physicians, to make it all happen. And we went around the country and found some great models, and we refined everything that we could in relationship to those places and customized them to working here. So 365, 24 hours a day, weekends, holidays, whatever the circumstance is, we provide robotic surgery. And there isn't a night, shall we say, after 11 p.m. at night that we aren't still performing a robotic assisted surgery. So we're proud of that, with the same results and outcomes that we see, whether it's day or night. We still see that high performance and that high commitment to excellence.
It's really important. And, thinking about all this standardization, right? All the efforts to really focus on reducing variation. I think it's clear when we talk about that, like the clinical, the outcomes benefits of that. But I'm curious, there's another component, which is the standardizing sort of robotic service line and lean processes really also help drive care team satisfaction. Dr. Talamonti, I'm wondering if you could kick us off on that question.
Well, all you have to do is pick up any newspaper or Google any website that provides daily news, and there's a national labor force problem, right? We see people that are leaving jobs in flocks if the job is unpredictable, if it's stressful, if expectations are unrealistic. And so the counter to that, though, I think, is to provide an environment where there's excitement about starting something new. It's innovative. There's a technology that they can be a part of. The nurses, the assistant techs, the entire perioperative team is involved in the robotic learning process. And with the standardization and the efficiencies that come with volume, someone mentioned the volume quality outcome. It's absolutely irrefutable that the more you do of anything, the better you become at it, and the more efficient economically and effective clinically you become. So when people can be a part of that kind of team, and they know that there's going to be more than a modicum of predictability when they go to work every day, and that their efforts are going to be viewed as a comprehensive part of patient care, that's an easy part to recruit. That's an easy position to recruit to. It's an easy position to retain people for, and then they can grow within that. So I think the whole emphasis on standardization and minimizing variation makes the workplace a lot less stressful, and retention is very much predicated upon being able to provide that kind of wholesome, exciting, nurturing environment where expectations are predictable and realistic. And then it gives people a chance to grow into leadership positions. And we've had really a remarkable experience with young nurses and young caregivers who say, I want to be a part of that team. That team's got they're the cool team. That's the team that everybody wants to be a part of. So I think the emphasis on standardization, minimizing variation, recruiting young gifted surgeons to robotic technology, I think it's a winning proposition across the board.
I mean, standardization, exciting, innovation, but also eliminating that uncertainty, so folks can come and be comfortable doing that exciting, innovative work.
Or Rick, otherwise they just leave,
right.
Or they leave.
Right.
And every industry in America is experiencing that now.
Mm-hmm. Right.
Yep. Rick, I want to hear from you on this too.
Yeah, I'm smiling because I remember the hours we spent discussing what was the ideal room layout. Because we grew in the number of robots, but we wanted everything standardized. We wanted all the rooms identical. We wanted all of the equipment the same, so people wouldn't have to compete over what room they were using. And I just remember the staff spending hours with the surgeons determining what was the best way to design the rooms to make sure the cables were at the right length and the right location, et cetera. And when you're a leader in that kind of world, all you do is feed them and just let them do their thing, because the result is always the best. And the team has constantly worked toward improvement. And as a result, it's a reproducible project every time. Our rooms are so well idealized and the same that we had to start naming the robots so that people knew that they were in a different room. And that's all because a group of people have designed their work to optimally care for that patient. The unique thing we have in our system and in our hospital in particular is our caregivers and their families get their care here, and they don't have to. We have 4 large health systems in this town. They are all good. You don't have to come here. We have 24 hospitals in our health system. You don't have to come here. But our physicians, the nurses, their family members, our corporate executives, all come here for their care.
Thank you, Rick. I really appreciate that. And I want to talk now about how you go about making some of these standardization choices, right? A big part of that has to be data, or how you really think about executing. So, Brian, then turning to you, how has having access to and sort of analyzing the most up-to-date data change the way you make strategic decisions for your robotics service line?
Oh my God, I'm a data geek, and as anyone knows, our surgeons are scientists, right? So data speaks volumes. So one of the things that we do is we make sure not only is the data correct, but we share it. We sit down with our surgeons, we go through not only their outcome data, we go through their cost data, we go through how well the team performs. I love the example that was given, and we're the same way. It's that team concept. How does the team work well? And we share all of those facets with each member of the team. So when we get together, not only are we sharing the surgeon's data with them, but we're sharing the room crew's data. On-time starts, turnovers. How well are you all doing in achieving the goals that we have, all leading to that positive outcome? So data is paramount. We go through it every month at every one of our meetings, and then spend the time with the robotics coordinators so they can sit down with surgeons one-on-one and walk them through their data. We include supply chain, we include quality, patient outcomes. We work with all the different departments that patient touches, because they can have a great surgical experience, and then post-operatively, we've got issues, and that taints their whole experience. So we make sure that everybody's working together using that data.
Absolutely. Thank you, Brian. And then I want to move into sort of this fourth bucket area, right? The lower cost portion of this whole conversation. So, Brian, we can start with you here. Can you share about how reducing variation in the OR has really impacted overall operations, and maybe share a bit about maybe some challenges that you ran into along the way and how you got around those?
Well, as I mentioned earlier, one of the things that we really started looking at was cost. And we wanted to dispel this fallacy that robotics is more expensive than laparoscopic procedures. Most people, it's a given. Robotics is, of course, a lot cheaper than an open procedure because the hospital stay is longer. But when we really started looking at the data, we really saw the value in robotics and minimally invasive procedures. And so what we did was we wanted to glean out the variation that had to do with supplies and equipment. Once we got all of our surgeons, together, and we looked at kind of a bell curve on cost and hospital stay, we started to compare practice. And as we found those who had really done an exceptional job, either on cost of equipment or length of stay, we started to duplicate those order sets among other providers. As we've heard from my other two colleagues, we took the variation out. And once we took that out, the dollar savings was very evident. So we started to expand programs. And the more programs we expanded, here is the recipe. So everybody followed the same processes.
Yeah, it sounds like eliminating that variation just really allowed you to grow and expand. Getting that variation out of the way was just, gave you a green light.
Right. And we used a lot of the intuitive data. There's data that we're pulling right off the machine, so why not use it?
Right. Dr. Talamonti, I'm curious what you would say on this question too, about how reducing variation in the OR has sort of impacted overall operations for you. Any challenges along the way?
Yeah, I'm fascinated to hear the discussion. Mr. Dawson and Mr. Harrell are obviously at programs that are further down the road in terms of the robotic transformation and the approach to minimally invasive surgery. So I'm learning a lot by listening to them. We're much earlier in our journey, and I would tell you that we've been at this now for 5 years with advancing complex general surgery and thoracic surgery, and there is a common theme, and that's about data being deafening to dissent. If you could provide the data, it quiets the dissenters. And why do I say that? Because when you're starting your robotic program, there will be naysayers. There will be people that say, oh my God, you're going to take so long in the operating room. There's going to be a learning curve. The equipment's so expensive. And how are we going to justify this financially? So actually, I went to the CEO in 2016, and I said, there's a care transformation on the horizon that's going to be irrefutable and immutable. And robotic technology is here to stay, and it's not just going to be for robotic prostatectomies or robotic hysterectomies. It's going to be pervasive in GI and thoracic surgery. And I said to the CEO, I said, but this is going to take time. It's going to take an investment in leadership and training, and surgeons are going to have to take time off to be trained safely. But most of all, I said, there are people that are going to come to you and they're going to say this is financially unwise. And I was fortunate to work for a very insightful and visionary CEO who said, listen, you can't climb every mountain your first year. So I want you to focus on decreasing length of stay and decreasing surgical site infections. And you do that, again, by standardizing care in the operating room, but also postoperatively in the recovery phase. And he said, if you can cut off an average length of stay of a day and a half in your complex hepatobiliary and pancreas patients, and you can do that in the first year of the robotic program, we win. If you can decrease surgical site infections with minimally invasive incisions instead of those big laparotomy incisions or those big thoracotomy incisions, we win. So actually, the cost savings, Brian, the first year, none of the metrics had anything to do with equipment, OR time, efficiencies in the operating room. It had to do with all the ramifications and the benefits of a minimally invasive surgery approach, emphasizing robotic surgery on the postoperative length of stay and the postoperative surgical site infections. Once we nailed that, all the dissenters were gone because it was self-evident that patients went home earlier after minor hepatectomies than they did with a robotic approach than they did with an open approach. So once we vested that hurdle, then we were able to come back into the operating room and say, okay, now every thoracic esophagectomy is going to be performed this way. Every robotic Whipple is going to be performed this way. And then you saw the costs in the operating room start to drop. Mainly, as Mr. Dawson said, first it was equipment, then it became efficiency and time, and then turnovers and things like that followed. But the very first metrics that we used to measure the impact of the robotic program was length of stay and surgical site infections. And that got us off the launch pad and gave us liftoff.
I really thank you so much for walking us through that whole experience, that sort of the data. Once you have the data like that, makes generating buy-in a little bit easier, because ultimately the data is the data. Brian, I think you want to chime in here, and then Dr. Talamonti, I've got a follow-up for you as well.
I just want to pick up on something that he said that I think is critical. He said he sat down, Dr. Talamonti sat down and spoke to his CEO. Critical that we who are establishing robotics programs bring the leadership into this, which means the CEO, the CFO, supply chain, because everybody focuses on, the supply cost. As our good doctor said, let's talk about length of stay first and tackle one thing at a time. So I just didn't want people to miss his point. Speaking with the CEO, CFO are critical in having a very well-run robotics program.
Thank you, Brian. Definitely agree with that. Dr. Talamonti, getting back to the intraoperative cost sort of component about this, we hear a lot about that. There's a lot of talk about lowering intraoperative costs. What have you seen drive the total cost of care for the patient?
Well, you can't dismiss length of stay. I never fully appreciated that. But if a patient goes home the next morning after a minor hepatectomy and 3 days later after a major hepatectomy done robotically, that's incomparable in terms of what happens when they have open surgery. I mean, the average length of stay for an open minor hepatectomy is about 3 to 4 days. And for a major hepatectomy, it can be up to a week. So that's still a prime driver in the motivation to build a robotic program. In the operating room, it's exactly what we've been talking about all afternoon. It is minimizing variation, standardizing care, and volume matters. It's an inarguable point of the quality metric that the more you do of anything, the better you get at it. And the better you are at something, the more efficient you are in terms of OR time, the more effective you are in terms of using personnel and staff. So all that happens, but it first start with something that you can measure and that makes sense to the patient. The patient wants to know they're going to go home in a few days instead of many days. They want to know they're not going to need as many narcotics in the hospital as they recover from surgery, and they're not going to have to worry about going home with a bottle full of narcotics. They want to hear that. Then you go back to the operating room, and as we said earlier, you recruit this team of young, enthusiastic nurses and caregivers. You partner them with innovative surgeons that are enthusiastic about implementing robotic technology for things like lung cancer and complex pelvic surgery. And suddenly people want to measure those other things that we've talked about, the cost utilization, reducing the number of instruments, but that all follows the idea that there's a team here looking at all the data. I love Mr. Dawson's comment. Transparency is the key. You don't get data to hide it. You get it to share it. And you share it with the nurses, you share it with the whole team. And then that builds a sort of a sense of momentum and enthusiasm about reducing those costs and reducing that variation. It's been an eye-opener for me at this stage in my career to see how people will embrace that. And it's fun. It's quite frankly, it's exciting to see.
Thank you so much, Dr. Talamonti, for walking us through that and sharing even more about your experience there. Rick, I want to loop you into this piece of the conversation here. I know you've recently standardized your Da Vinci system fleet. Could you highlight some of the financial benefits of that effort?
Sure. Well, first of all, I have to say the last robot that I received, the CFO called me and asked if I could use another robot. That's when I considered it was real success for a program. Because we clearly had come through, as my colleagues have discussed, all of the transition to have the outcome that everyone in the company noticed that we were such high performers when we actually performed this. So as every one of my colleagues has said, we committed to it. There is a particular culture in our hospital that we have to pay attention to, and that is we talk about a patient's outcome and result and benefit before we'll talk about how much it costs. We will not start that conversation in the reverse, ever. And so as a result, everyone is focused on making that patient experience the best, and the caregivers and the physician. And that gives us, people standardize as a result of having the ideal experience, whether you're working or receiving care. And so we've then measured what are our results in relationship to the excellence that we have been able to perform. And so the buy-in is great for my staff because now they are the ones who are coming up with the ideas. I love supply chain and all the other entities that are in our company that support us, but I am very clear with them. You are here to support the patient care. It does not drive the patient care. And that means we're all committed to that. And we do whatever we can to make sure it's an ideal experience for the patient and the providers. And as a result, we have seen year over year improvements in our operational performance. And we do pay attention to it and we share it openly. But most of the time these days is not our first focus. Because we do everything the same way. And what we have been able to achieve with robotic assisted surgery has spread to our other disciplines in the procedural area. Everyone wants to be measured against the robotic assisted surgery team. So that level of competition is also healthy.
Thank you for sharing that, Rick. I love it. It starts with the people, right? It's all about the people. You know, we've just got a few minutes left together. Time has really flown by. I want to ask one final question before we get to a couple audience questions. So maybe 30 seconds or so. I want to know, you know, what's next? What's coming? What are your next steps for your robotic service lines, and any strategic initiatives you can discuss with our audience moving forward? Rick, we can start with you.
Sure. Yesterday, we started the ION diagnostic process with robotic assisted surgery, your ION device. And that, again, created a whole new culture because now we're trying to have this as a single anesthesia event. The diagnostics, the biopsy, as well as a treatment if it's needed robotically. So it's created a whole new team of individuals. Our interventional pulmonologists and our heart surgeons are now engaged, and thoracic surgeons. And so it's created yet another environment. And we idealize the team with some of the best performers and to create the best scenario initially. And of course, because we want to be able to have that service available at all times, it will have to continue to grow. So we will look at any opportunity that we can to minimize the invasive nature of any surgery. My particular position is I am not competing with an ASC. I don't compete with an ASC. If it can be done at ASC, go with my blessing. When you come here, you're going to have the highest tech, highest quality, best performers, and the equipment that necessarily you cannot get anyplace else, and to have this kind of experience. And so we will continue that as our motivation. So as technology is available, we will continue, but single events, moving more and more and more to single day stays, extended recoveries with patients going home, reducing the amount of narcotics, again, continuously improving. I think my major surgeon said the other day, I think we're down to 4 pills on discharge, Rick. So, you know, that's what we see. And as long as we can continue that, and my colleagues here, when they come up with a great idea, we try to see what is our version of doing it.
Thank you, Rick. Brian, throwing it to you, then Dr. Talamonti.
Just real quick to dovetail off of all the things that Rick said, you know, our major goal in CommonSpirit, you know, for those who don't know about us, we are 2 systems that came together, Dignity Health on the West Coast and Catholic Health Initiative. So we've got 120 plus hospitals. And one of the things that we're trying to do is to take that same quality that we've got at facilities in the Pacific Northwest, facilities in Arizona, spread that through Texas, through the Midwest, through some of our smaller hospitals, to make sure that having a robot is not a program, that we help everyone create a robotics program. And with the help of Intuitive and our latest contract, we're bringing everybody the best quality, newest technology, and creating those programs across the enterprise.
Thank you, Brian. Appreciate that. And Dr. Talamonti, why don't you take us home here?
I again, as a physician and a surgeon and a department chair, my emphasis is much less on the economics of robotic surgery and those systems that have Mr. Harrell and Mr. Dawson running their robotic service line. They're very lucky because they're obviously very facile and very knowledgeable about the business side of it. For me as a department chair, and as I see the momentum to adopt robotic technology, be it complex hernia repairs or thoracic surgery or colorectal, it's about making sure that we bring our doctors that our doctors bring this technology on safely. And so as our healthcare system expands, when I got here, it was 3 hospitals, now we're up to 9. And as physicians within the system want to embrace robotic surgery, I feel it's really important that we put training programs in and that we credential surgeons appropriately, that there's review of their outcomes, that there's proctoring when somebody is starting a new procedure that they haven't done before. This is not experimental surgery, it's innovative surgery. And so I spend a lot of time now with my leadership, not only looking at standardization and minimizing variation, but also establishing training and credentialing standards. And remarkably, it's been embraced. The surgeons haven't said, well, I know how to do this. I've been doing this for 10 years laparoscopically, and now I'm just going to jump on the robot and do it robotically. They haven't given me any of that pushback. On the contrary, I think they understand that robotic technology is enabling, but it's only going to be optimized with the right training and proctoring and experience. So bringing it on safely, slowly, smoothly, without terrible outcomes. I think that's the thing ahead of me, because there's been a real rush to embrace the technology as they see others doing it. But now we want to make sure that we do it safely.
Thank you, Dr. Talamonti. I think that's a great place for us to close out here. Apologize for audience questions. I know we'll continue to engage with you, but we are at time, and I want to be respectful of everyone's time. So Rick, Brian, Dr. Talamonti, again, thank you so much.
Thank you.
Thank you,
Thank
Brian.
you.
Best wishes, everyone.
And to our audience, thank you as well. You'll now have a quick break before you get to your next session. Please do remember to complete the survey at the end of our time here. We always want to continue to get better. So thank you so much.